Hello everybody, welcome to our first complex, or the only complex exam. I would like to show you my PhD topic, which is identification of predictive and prognostic biomarkers in polyposis syndrome. My name is Judit Jockers. I'm a PhD student and a pediatric resident currently on maternity leave at Semmelweis University. My supervisors are Miklós Garami and my SMS is Mark Hernatfői. I have two ongoing topics. My first one is investigating the association between the genotype and phenotype of pediatric patients with polyposis syndrome, where we would like to develop a systematic review and a meta-analysis. Shortly about the background. So, polyposis syndrome is a group of hereditary diseases characterized by multiple gastrointestinal polyps and an increased risk for cancer and other conditions. They are caused by genetic mutations which alter the function of the affected genes, thanks to a new generation of sequencing and modern methods, it is possible to detect these mutations and find the clear background of the disease. Still, there is no clear genotype-phenotype correlation been demonstrated yet. For these diseases. Cancer and other conditions are extremely rare in these children, and the recommendation regarding their management remains poor. Therefore, the aim of my study is to investigate the possible outcomes in association with the genetic background in pediatric patients with polyposis syndrome to predict the course of the disease, make an early diagnostic possible, to find the best management option and to improve the quality of life and enhance chances of survival for these patients. My clinical question is, what is the association between the genotype and phenotype of children in polyposis syndrome? Where my populations are children, the exposure is the genetic variances of the polyposis and the outcomes are the different phenotypes depending on the diseases. My hypothesis is the genetic variances of polyposis syndromes can be associated with clinical variabilities. My implications toward the patients is to improve their quality of life, for clinicians to find an early diagnostic method and to find the accurate management, and for researchers to find the best therapy option. We use the search key you can see below with three domains of the population, the polyposis syndromes and the genetic background and the phenotypes. And overall, we had 19,820 articles, and after duplicate removal and eligibility studies, we had 108 eligible full texts for our study with the following outcomes. So we included three different polyposis syndromes: the familial adenomatosis polyposis syndrome, the Poids-Segers, and the Peden hamartomatosis polyposis syndrome. And each syndrome had different outcomes, you can see below. We divided them into intestinal and extraintestinal manifestations, depending on the typical outcomes for the diseases, and we made an association between the phenotypes and the genotypes. And let me show you my three outcomes of the different diseases. First, I would like to start with familial adenomatosis polyposis syndrome. I'm sorry, this slide moved a little bit, it's hard to detect. So here I would like to show you the association between one outcome, which is desmoid tumors in familial adenomatosis polyposis syndrome, which is a severe extraintestinal manifestation in association with domains in the APC gene. Shortly about the background for the APC gene, it's a pretty large gene which contains 15 exons overall, and a few, and within those, and there are functional domains. The exon 15 is the biggest exon for this genes, and until now they found that most of the mutations are in exon 15, and also exon 15 contains most of the functional domains. Here we can see my results. So overall we had 97 patients in my search for familial adenomatosis polyposis syndrome. And here we can see the division of the domains, and we had the biggest found that the SMP region, which is found in exon 15 and armadillo region, also in exon 15, had the biggest pooled proportion with around 20%, with an overall prevalence of 16% in these patients. These findings are not significant, although clinically they are really relevant for the study. My next is about the Peutz-Jeghers syndrome, where you can find a mutation in the STK11 gene, and one outcome is the interception, which is a severe complication in the disease where a bowel moves into another part of the bowel due to a polyp in the small intestine. And also here we looked at the dividing into the exons, and to previous research we can see that we divided into exon 1, exon 2 to 7, and exon 8, because most of the pathogenic mutations are found in exon 8 usually, and in exon 1. In our study we can see the same. 89% of the patients with the pooled prevalence show a mutation in exon 8, and the second is in exon 2 to 7, showing that most pathogenic interceptions are in exon 8. The third one is about the P10 hamartomatosis syndrome, where developmental delay is one of extraintestinal manifestations. Here we can see the association between the molecular consequences and the outcome of the phenotype. Here we had a pretty big number, although the literature says that it is not too common. We had 64 patients who showed developmental delay, and most of them were found in truncating mutations. So we had several strengths and limitations for my study. The strengths were that we had individual patient data, and we could map the genotype-phenotype according to it, and we had standardized endpoints in the end, with clinical relevant insights for surveillance and management. Although the limitations were that we used mostly case reports in small series, therefore we had a low patient number, and also referral bias in the articles, because there was sometimes themed according to a special outcome, and also heterogeneous surveillance and practice. Also in the articles, sometimes we had incomplete variant reporting, therefore we had sometimes no certain genetic background, and the domain level conclusion was also mostly hypothesis generating, because we had no significant outcomes, only tendencies to see. But still we had some conclusions for the different diseases. For familial adenomatosis polyposis syndrome, we found that polyposis is nearly universal, and that desmoid tumors, which is a severe outcome for also a Gardner's subtype, is clustered in the distal exon 15 region, and also a congenital hypertrophy of the retinal pigment epithelium was almost universal in the patients. This is an implication in practice that we should start colonoscopy around the age of 10 to 12 years, and to plan to make a desmoid surgical strategy if we find variants in the distal exon 15 region, and to plan a colectomy based on the phenotype and not on the age in these patients. The congenital hypertrophy of the retinal pigment epithelium is not a severe extraintestinal manifestation, but it could lead to a diagnostic clue which could be used in children. In the Peutz-Jeghers syndrome, we had several outcomes as well. For example, that small bowel polyposis was nearly universal, and the mucocutaneous pigmentation is also universal in the patients. The interception is frequently in exon 8 and the kinase C terminal variants, which implicates for the practitioners that they should look at the genetic background and focus on preventing these obstructions in those patients. For PTAN, we had different conclusions as well. We had rare gastrointestinal polyposis in pediatric patients, and macrocephaly was nearly universal, which means that this should trigger a genetic evaluation in the pediatricians, and also neurodevelopmental assessment should be a part of the management in these children. Another outcome was that we had a lot of benign thyroiditis diseases in this disease in children, but the transformation into cancer was pretty low. So routine surveillance should be for endocrinological outcomes, but the operation should not be early. So we submitted my paper yesterday to the JAMA Pediatrics with our outcomes, and we hope to get some relevant feedback. And very shortly about my second disease, colectomy and timing and indication in polyposis syndrome, impact of mutation type and clinical features. Just one sentence and I finish. So here our goal is mainly to look for patients with polyposis syndrome, mainly in FAP patients, in FAP pediatric patients, where colectomy is usually made too early or too late, and we want to find the best time for colectomy in these patients. To summary, I want to find the best management option for these patients, and to learn about these diseases deeply to implement a healthy life for these patients. In the end, the important thing is to never stop questioning. Curiosity has its own reason for existence. Thank you very much for your attention.
Thank you. Perhaps it was too hard to detect the figures. To tell the truth, I couldn't see anything from your figures. So if you would like to summarize in 2 sentences, what is the main message? They were very, very busy slides with a lot of information. But what is new? What is new? Because we know that polyposis syndromes has a danger, has a risk, has problems, even in pediatrics, but later on mostly in adulthood. So after your research, what is the new conclusion in 2 sentences, in contrast between new 10 years ago or 20 years ago?
Thank you very much for your question, and I'm sorry that it got so complicated. It was a very big topic, and my main message is mostly that the genetic background should be used for clinicians in the everyday use in the management for pediatric patients, because there are details we found which are not in the management we can see today. Like in the protocols, it's age-based or sometimes not even concretely written down what to do in these patients. And with my study, we could find outcomes with tendencies that show for each mutation and the location of the mutation, basically, in what direction the clinician should go for the management in these patients. Of course, it's a lot.
But on your slide, it would be logical. So earlier we saw that we have to do the colectomy or something like that at the age of 10 or something like that.
Yes.
Your conclusion was that perhaps not the age, but not the genotype. It was on your slide that the phenotype is the most important. And you are talking now about genotype, and the conclusion was phenotype is the most important. So I didn't understand. What does it mean, phenotype?
Yes.
If you have a tumor, of course, it has to be operated. So I'm confused, to tell you the truth.
Yeah. So today the protocols are age related.
Yeah.
What I am saying is that you should look not only at the age, but at the phenotype. So how the disease in the, yes, but because it's the association between the phenotype and the genotype. So we should look mainly at the phenotype of the patients together with the genotype to find a specific management outcome for each patient individually, and not in a big cohort showing that these are patients with familial adenomatosis polyposis, so we have to make a surveillance for desmoid tumors with ultrasound every 3 months, as it's written down now. I am saying that if they have a genetic variant that never had a desmoid tumor, for example, before, it is not important to make the ultrasound every 3 years, but to look at the patient individually with the genotype together, and according to their phenotype, find the best management for those directions. Like
regarding the data in the last decades, you mentioned that the malignancy and the tumor occurrence is very rare in childhood. But what time is this coming? Do you know from the adult data, or perhaps you know from the adult data? What is the timing? Perhaps at 10 years for colectomy it's too early. Perhaps, okay, genotype is important, phenotype is important, but the whole story should be moved a little bit later on. I don't know, I just asked. So what is the occurrence, what is the typical time of occurrence of malignancy for this syndromes?
So it's depending on the malignancy itself. For example, we also we looked after the age of onset for the different tumors. And what I can say, for example, hepatoblastoma is showing that they mostly appear between the age of 0 and 5 years in familial adenomatosis polyposis syndrome. So the surveillance should be in this age group. Desmoid tumors usually occurred around 10 to 12 years. So we had to, so my suggestion is to look for desmoid tumors not with ultrasound but with an MRI in this age range. Colorectal carcinoma, we had only a few cases which showed an association with different genotypes. So our result was that colectomy should not happen in childhood, except if there is a high-grade dysplasia found in the polyps. And cancer is ultimately rare. Like we had out of the 97 patients, we had 3 patients with colorectal cancer with a very specific genotype. And the age was also after 16 years.
Congratulations, first of all. It seems like it's been a lot of work with all the papers. I cannot imagine the amount of work to extract all the data and screen all the articles. I have a more technical question regarding the method of genetic testing, because you have older studies and newer studies, and this has changed over time. And I assume that the cutoff for positivity, for variant calling, or may vary depending on the testing method. And I wonder whether you try to stratify by the testing method, or you find higher associations with the newer methods. Are they more sensitive to certain genetic alterations? Have you tried to look into this? Because I imagine that this has changed, and maybe we are better at detecting the alterations with the next generation sequencing and so on. If you have any insight on that.
So yes, we actually, in our first search, we had 200 eligible articles. because we also put the articles before 2000 in it, but the genetic testing before 2000 was not as precise as the genetic testing we know today. And yes, we also compared the genetic testing. So the difference was actually that genetic testing before was usually in the polyps themselves and not from the blood, so not the germline. And we excluded those articles because we know that the soft tissue data is different to the germline data, and we want to see like the whole patient and not only the part of the tissue. So that was one point that why we decided to put in only articles after 2000, and the rest, like most, I also looked, but to be honest, not completely. Like I looked at the articles and saw if it was the same method they used for genetic testing. Then we added the article because everything else gave us different outcomes. But if we had patients who had the sequence with the protein, with the exon, then we included, regardless from the type of how they looked into the genetic background, basically, because they had the information that we needed.
So you stratified.
Yes.
Thank you. I'd like to congratulate on your project. And my question would be, do you know how much these genetic testing costs per patient? So how easy would it be to use it in the clinical practice?
That is a very good question. Thank you very much. To be honest, I think it differs very much in every country. And to be honest, I'm not sure what the costs are for genetic testing in these patients. But thank you for your question. I will look into it.
Question. I wanted to ask whether this type of screening is available in Hungary, or if not in Hungary, then where in other countries?
It is available also in Hungary. Like we are doing genetic testing for patients with polyposis syndromes. And I think it's available like in most of the countries. I did not, of course, European countries and the USA, because it's not like today. It's getting better and better to find a method for genetic testing.
Thank you.
I think it's getting cheaper and cheaper in every field of the medicine, and I really hope that Hungary is able to do everything what is necessary. But for example, for other oncology, I'm a hematologist, so genetic testing for the whole sequence of leukemia panel or something like this is similar to your study. It's less than 1,000 euro now, so it's not so expensive.
I have a short question related to the analysis. First of all, if I remember correctly, you showed forest plots, so meta-analysis results, but you also mentioned among the strength of the study that you had individual data available, right? Did you take, or do you think that you can take advantage of those data to fit like a direct model, like a mixed regression model?
Thank you for your question. It's a very good question. Well, we're actually still working on the project because it's so huge, and we want to find advantage in those, but I still need to work with the statisticians to look into these specific data.
Because I think you mentioned, and we saw that the problem is the lack of significant results, but maybe exploiting that will be more powerful for the analysis, so I would recommend.
Yes,
and also just one recommendation, if I can do that for the future, that when you have such forest plots, it's really not easy to fit into a presentation or to a paper as well. You can prepare summary plots where you can only see the group summaries, so it's a bit more easier to digest, and then you can leave the huge figures to the supplementary material. Okay, thank you.
Thank you very much. I was hoping that it zooms inside, but it did not work here. I'm really sorry.
to ask how to diagnose polyposis syndrome. What are the main clinical signs which are the first step to why is it suspicious? So
yes, thank you very much for your question. It's a very good question, and well, it depends on the polyposis syndrome, of course. So dividing it into the three groups, familial adenomatosis polyposis syndrome is the polyposis syndrome mostly found in pediatric patients, and it usually starts with bowel problems. So bleeding, with the children are saying their tummy hurts a lot, or also other findings, anemia, for example, in the blood work can show, but so then these are the first signs, and not finding anything else could show that it could be a polyposis syndrome. And of course, the endoscopic is the final for FAP. But for example, in the Gardner subtype, it's not only the bowel that is causing problems. There are osteomas or dental abnormalities. So it's depending on the field, like where the child is going first. A clinician, I think, has to know the signs and has to think about it if they see something like that. For P10, where, for example, polyposis is very rare in pediatric patients, it's mostly in the adult patients. Macrocephaly was very universal in our study. I think like 99% had macrocephaly, which is growing out by age. So if we see newborns or little children with macrocephaly, a clinician has to think about polyposis syndrome.